So my name is Kasparis Briedis. I'm a lecturer and a PhD student at the Lithuanian University of Health Sciences. And I'm also a consultant interventional cardiologist, mainly focusing in structural heart interventions at the Hospital of Lithuanian University of Health Sciences Kaunas clinics. So the Vienna Aortic valve system consists of dehydrated bovine pericardium that is mounted on the radiopaque Nittilon self-expanding stent system, actually designed for a supraannular positioning to optimize the hemodynamic flow. And it also has a pericardium fabric external skirt that covers the inflow portion of the valve to diminish any risk of paravalvular leak. Furthermore, what distinguishes this valve from other valves on the market is that the Vienna aortic valve is already mounted on the delivery system in the manufacturing facilities, so that the system is ready to be used anytime, eliminating any need for valve crimping and assembling during the intervention. So this innovation saves time, resources, also avoiding potential human use errors in the cath lab. It also allows to be stored in all hospitals, facilitating its use at any time in daily clinical practice, even in emergency situations. So in other words, it's like it's off-the-shelf device. The system is also enabled to be resheeted back to the capsule or to be fully recaptured before it is fully released from the delivery system. And this ability to resheet or recapture the device allows the operator to reposition or remove the bioprosthesis if the initial positioning is suboptimal. That is a key feature because it facilitates the device accurate final positioning, also minimizing the risks of any suboptimal positioning, such as paravalvular leak, acute migration, embolization, or any AV node conduction disturbances related to implant death. So the Vienna valve comes with in 4 different sizes and is available for a wide range of aortic analyse diameters derived from its perimeter, and starting from 8 millimeters and covers up to 29 millimeters. And it also has a delivery system, which some of you are already familiar with, because the same delivery system is being used for the trick valve technology for tricuspid regurgitation and right heart failure. So the distal deployment end of the system features an automatic radiopaque tip and the capsule that covers them and maintains the bioprosthesis in a crimped position. The handle is located on the catheter's proximal end and is used to load, recapture if it's needed, and to deploy the bioprosthesis. And the handle includes a micro slider to open and close the capsule, and also a micro knob to facilitate the precise bioprosthesis placement. So this micro knob is turned counterclockwise to load and recapture if needed the bioprosthesis, and also turned clockwise to deploy the bioprosthesis. So it's a single system for all valve sizes, and if it is used sheathless, it needs around 6 millimeters minimum in the artery diameter. So looking at the procedure itself on these slides, you can clearly see that the final excellent angiographic results of 2 different patients, and there is no paravalvular leak observed. And even in this listed anatomy of the aorta, in horizontal aorta as well, on the right picture, you can see the valve is deployed in an incorrect anatomical position. So several preclinical studies have been performed to verify the function and the safety of the Vienna aortic valve system. And in biocompatibility tests, the device has satisfactorily met all recommended requirements to be applied in vivo screenings. So acute data from subsequently conducted animal studies in sheep demonstrated reproducibility as well as a safe and accurate deployment of the valve in a defined position. And the immediate performance of the valve met expectations from bench testing as well, and no thrombus formation was observed under anticoagulation therapy. So basically, based on these results, a promising safety and performance profile is expected of this device. So given that the medical device is potentially a long-term treatment for patients with severe aortic valve stenosis, the next step for market approval of this new technology is to demonstrate the safety, feasibility, and even the hemodynamic performance of the device at 30 days, which is defined in the protocol as pre-market data, and up to 1 year during post-market clinical follow-up data. In this interventional clinical trials in patients with severe symptomatic aortic valve stenosis who are basically rejected for surgical aortic valve replacement or evaluated to be high or intermediate risk for open heart surgery by the heart team. And all the objectives and endpoints were chosen based on the recommendations given by the Valve Academic Research Consortium for TAVIs. So this is a prospective, non-randomized, single-arm, multi-center clinical study, which is divided into 2 stages. One which started with the feasibility study in 10 patients, and which already been followed by a pivotal study in symptomatic patients with severe aortic valve stenosis. So this study consists of 7 visits spread across 2 phases over 1 year, and the clinical investigation will end up at 30 days post-implantation, after which a full clinical evaluation will be presented for a CE mark approval. And the subsequent 3, 6, and 1 year follow-up visits will be considered as a post-market clinical follow-up phase. So in this first-in-man feasibility study, we evaluated the safety and the feasibility of the Vienna Aortic Valve system in 10 patients diagnosed with severe calcified symptomatic aortic valve stenosis. And all patients included in this study met all the study's eligibility criteria. And the safety and feasibility assessments for these patients included implantation success, hemodynamic performance, and also monitoring for any adverse events. So the study consisted of primary safety and secondary safety endpoints. So the primary safety endpoint was successful in all patients included into the study because they did not have any all-cause mortality within 30 days after the procedure. Looking at the secondary safety and even performance endpoints, we were also successful in achieving to don't have any incidents of peri-procedural death within 3 days after the procedure. Looking at any related complications from the TAVI procedure itself, we had 1 evidence of new pericardial effusion reported after the procedure, and it was seen that there was a temporary pacemaker lead perforation of the right ventricle. And those, we didn't find any vascular complications, any coronary artery obstruction observed, any prosthetic valve endocarditis, thrombosis, or a mispositioning or embolization of the valve. So this part of the secondary safety endpoint was successful in 9 patients out of 10. So looking at the device success itself, which is defined as the correct positioning of a single prosthetic device in the desired anatomical location, was successful in all the patients. Also, the technical success, which is defined with a successful vascular access, delivery, and the deployment of the investigational device and successful retrieval of the device, was also successful in all the patients. We had some conduction disturbances in 2 patients. 1 patient had a complete heart block after the procedure, but it's worth mentioning that on the baseline ECG, this patient had a pre-existing first-degree AV block with a complete left bundle branch block. And 1 patient had a symptomatic sinus bradycardia without a complete heart block, and this also ended up having a permanent pacemaker implantation. We had 2 cerebrovascular events, one of which was acute and one which was subacute. They both were non-disabling strokes, unlikely related to the investigational device, and the patient fully or partly recovered after the stroke. So when we look at the valve performance, even at the discharge or 30 days follow-up results, we see that there was a significant drop in the mean aortic valve gradient, even to a single-digit number. And also, we observed a really large mean effective orifice area after the intervention, which is basically mainly driven by the supraannular design of the valve. And when you look at the 30-day follow-up, only 1 of the patients with a severely calcified aortic annulus and critical aortic valve stenosis had a moderate paravalual leak and the others either didn't have any or only had a mild PVL. So Data and Safety Monitoring Board evaluated the early first-in-man feasibility study data from these first 10 patients and recommended continuation of the study enrollment. So overall, 100 patients will be enrolled in the study and for the pivotal study. So 75 patients are planned to be recruited at 5 to 12 different centers in 2 to 4 additional countries. And moreover, 15 more patients will be enrolled for the post-market clinical follow-up phase as well. So all this data together will be analyzed together for the pivotal study endpoints to obtain the market approval. And the clinical trial is completed after all 100 patients that are not prematurely withdrawn have completed the 1-year follow-up visit that involving all specific assessments. And after completion of this prospective interventional study, all patients are offered to continue evaluating their valve function and health status for additional 4 years as a part of the post-market registry. And this registry, which will be included in the post-market follow-up phase plan, will allow us to gain information concerning the long-term safety and performance of this new Vienna aortic valve system.